Welcome and good afternoon, everyone. My name is Jim Taylor, and I am the Chief Equity Officer here at the Urban Institute. I'm so glad that all of you could be with us here today. Now, before we jump into today's session, I just want to cover a few housekeeping notes. First, we are broadcasting and recording this event. The recording, the slides, and all additional content will be shared after the event. We've also enabled live captions, which you can turn on by clicking on the CC button, the closed caption button, on the bottom right corner of your media player. And we also want to engage with the audience both online and in person. So to ask questions, if you're a virtual attendee, please feel free to type your questions into the Q&A box at any time. And for those of you who are attending here in the room in person, you can access the event dashboard using the QR codes on the tables at which you're sitting. Please contact events@urban.org if you need technical assistance at any time. And if you would like to join the conversation on Twitter, please use the hashtag #liveaturban. And lastly, we really do want to get your feedback on today's event. So afterwards, we're going to be emailing a link to a post-event survey, and we ask that you share your feedback with us because it's helpful for us and for panelists to hear what you're thinking about, and because it will help us shape what we will do in the future. So that takes care of the logistics. Now I just want to say a few thank yous, really. In addition to thanking all of you for joining us, I want to thank the American Benefits Council and Deloitte Health Equity Institute, two organizations that have worked closely with Urban in exploring key insights on solutions to improve the collection of self-reported race and ethnicity data. We are thrilled to have experts from each of these organizations joining us as speakers today. I also want to thank our funder, Elevance Health, and I'm so glad that their Chief Health Officer, Shantanu Agrawal, will be joining us as a panelist today. So now, let's delve into the topic of today's event. As we work to create a more equitable society, we must turn to one of the most important tools that we have to do that, which is data. Our Health Policy Center has produced research which shows how structural racism has driven long-standing racial inequities in healthcare access and health outcomes. Now, these inequities show up in several ways, including, but not limited to, the lower rates of cancer screening overall and later stage cancer diagnoses for certain types of cancer for people of color compared to white people, maternal morbidity and mortality rates for Black and American Indian women that are 2 to 3 times higher than for white women, and the recent ruling of the Supreme Court overturning Roe v. Wade, which will disproportionately impact people of color. We know these facts because of the health and race and ethnicity data that were collected. But if we don't have complete race and ethnicity data, we can't do the work that is needed to not only understand, but also to address inequities in care. The event today will feature a discussion of the opportunities for improved race and ethnicity data collection to advance health equity and findings from the report out today on key barriers and solutions to more complete data collection for use by health plans and others to advance health equity. As one interviewee stated in the research for this project, the absence of data hides injustices in systems of care. So now it is my pleasure to introduce our keynote speaker, Ali Khawar. Ali is the Acting Assistant Secretary for the Employee Benefits Security Administration at the U.S. Department of Labor. Ali has vast government experience and has previously served in a variety of roles at the Department of Labor, including as an Employee Benefits Security Administration investigator, in EBSA's Office of Enforcement, as EBSA's Chief of Staff in 2 administrations, and as a counselor to the 26th Secretary of Labor, Thomas Perez. Mr. Khawar has a bachelor's degree from Johns Hopkins University and a law degree from Emory University School of Law. Acting Assistant Secretary, it is wonderful to have you with us today, and now I'd like to welcome you to the podium.
Thank you, Jim. There's a lot of Jims to thank today. I appreciate the invitation. So I'm going to keep my remarks pretty short. But I wanted to talk to you a little bit about why I think this is such an important issue and how excited we are that a convening like this is happening. To state the obvious, I just want to echo what Jim was saying. We know that when you look at things like the coverage rates in the employer-sponsored system, uninsurance rates, that there are significant disparities. But we also know, if you think about social determinants of health, that the systemic inequities and structural racism in society is kind of reflected in all kinds of facets. And many of those, of course, that's why we call them social determinants of health, because they really impact health outcomes. So it's critically important to have this conversation. And in part, because data is, as Jim said, a critical piece to figuring out how we can fix this. It's not, I don't think it's important for us to collect the data to show that there's a problem, because there really shouldn't be any debate about that. There is clearly a problem. But what we need to figure out is how we can address the inequities and how we can actually make things better for millions of Americans, not just the ones that are in the system that we regulate, the employer-sponsored insurance system. So to me, the value of the data is in a slightly different thing. It's in figuring out what are the answers to these problems. How can we design solutions? And critically, how can we evaluate them? We can all come up with good ideas, but the data is really the way that we're going to be able to know this is something that works. This is an intervention that sounded promising but needs to be tweaked, or needs to, frankly, even maybe be abandoned, because it's just not the thing that's driving the kind of outcomes that we want. The other point I would make, though, about the data is that, again, I'm someone that is a big believer in data, but these issues are so important to all of us that we really shouldn't view the data as a precursor to taking action, because I don't think these issues give us the privilege of waiting until we've got pristine data. Really is incumbent on whether you're watching virtually or whether you're in this room, really is incumbent on all of us to do everything we can to try and address these problems as quickly as we can, because frankly, it's well past time. I don't think we would have been having this conversation 5 or 10 years ago. There is a moment that we have right now in this country where you have, I think, a remarkable cohesiveness in terms of the commitment that very different stakeholders have to these issues. I think that's reflected in today's convening, the diversity of the stakeholders, and I don't mean that in kind of the race and ethnicity sense, but just the various perspectives that we have and the places that people are coming from. It's kind of unique. It's not something that I've seen in the past few decades in the ERISA space or otherwise. So I think it's really incumbent on all of us to take advantage of this time. I think, again, the data is a critically important part of that. But I just want to say, I think for all of us, I'm not in my office, so I don't have the flags and eagles behind me, but I will say, frankly, as Americans, we need to view these issues as a shared problem. And we need to view tackling them as a shared obligation for all of us. And I will just say, I think we all have a part to play in fixing it. And I'm really glad, ABC, Urban, Deloitte, I'm really glad that this work has begun. It is a beginning. And, from the Department of Labor's perspective, and frankly, from the administration's perspective, these are really important issues to us. And we look forward to working with all of you as this journey continues and figuring out how we can be a partner, because, I think there's a role for the private sector, there's a role for the nonprofit sector, and absolutely, as this report talks about, there is a role for government as well. So I'm really excited about today's conversation, but I want to leave you with just one thought, which is the point I made earlier. The data is really good, the data is really important, but we need to do a lot more, and we can't really wait to figure out all these things to start addressing the kind of problems that we're facing. But thank you, and I look forward to today's conversation.
Thank you so much for those remarks. That was a great way to set the stage. So Thank you all for being here. I am Jennifer Haley from the Urban Institute's Health Policy Center. And just thrilled for all of you to join us in person as well as online. So I'm excited today to present a few thoughts from a paper that we have released today along with the American Benefits Council and Deloitte with support that we're grateful for from Elevance Health. So we did a variety of types of research for this report. We did a literature review, a legal analysis, Deloitte and ABC led surveys of individuals and employers respectively. We did interviews with dozens of stakeholders and a summit for data collection. And the stakeholders were really a really broad group of people: health plans, technology firms, providers, employers, community-based organizations, foundations, advocates, and so on. So we got a really broad view of the folks who are interested in this topic. So I'll provide an overview, and then I'll hand it over to my colleagues at ABC and Deloitte for more. So as introduction and background, as you all know, there are vast disparities in terms of health outcomes across racial and ethnic groups, and health plans are in a unique position to understand and address some of these issues because they have such a broad view of healthcare utilization. But prior research shows that this data on race and ethnicity is limited. So it varies across the lines of business. For instance, Medicaid enrollees, data's pretty good because it's asked at application. But for commercial members, not so much. And even when the data are collected, they're often incompatible or lack sufficient detail. So even though this has been a known problem, it just hasn't been addressed yet. So this work was to bring various stakeholder suggestions for how to improve the collection of race and ethnicity together. They identified a lot of great solutions and next steps. And today I want to talk about 5 key barriers to complete and accurate data collection that were raised during our interactions and some of the solutions they identified. Sorry about that. I haven't been in front of an audience in person like this in quite a while, so this is very exciting. So first, lack of understanding and communication of the opportunities of improved data collection for health equity. In particular, what is the role of health plans in that process? That was something that came up again and again, that people don't really see the reason behind this push. Second, individuals' trust. Many stakeholders that we talked with worried that individuals just don't feel comfortable sharing their race and ethnic identification with the healthcare system. They just don't trust that it's going to use the information effectively. And so they just might not be willing to provide it. Third, legal concerns and uncertainty, especially among employers. Fourth, outdated data collection processes, by which I mean, how are we asking about race and ethnicity? You know, what's the question? How is it worded? What's the reason and the context in which it's asked? And what are the categories that people are given to respond? And then fifth, insufficient prioritization across the health system for this issue, including of funding. So I'm going to go through one by one some of the great solutions that our stakeholders identified. So in terms of widespread understanding of the opportunities of this data collection, they identified a lot of really interesting examples that could serve to clarify the value of the data. So for instance, internal monitoring of health equity patterns and trends. So because the health plans have a great view of all the utilization of someone, and can understand their engagement and their satisfaction, they can see how this varies by subgroups and maybe track over time whether those subgroup differences change. Several identified the need for greater accountability. And so this could include public reporting of providers or plan level outcomes. In fact, some said that a plan could produce on a provider or on themselves sort of a report card. How well are they doing on equity? And then consumers or employers who are purchasing from a certain plan or might go to a provider could hold them accountable for improving health equity. Another example that came up was identifying where additional healthcare resources are needed. And one of the summit participants gave an example of finding if in a certain area, a certain racial or ethnic group had worse outcomes than others in that area, they could work with the community to target interventions to that specific subgroup in that area. Fourth, of course, I'm going to bring up research, but the plans could also do research to understand which health interventions are really helping equity, and then, of course, the important next step of evaluating, were those interventions effective? And a final example I'll mention is about algorithms. So we heard that plans use treatment and other decision-making algorithms. They might be developed using AI or machine learning, but even if the algorithms themselves don't have race and ethnicity built in, they could be, if they don't have accurate race and ethnicity data to test them, they might not know whether there's bias in the algorithms. And if they could test for bias with complete and accurate data, they would know whether or not they should be deploying an algorithm that might be biased. So stakeholders said that if we could have a broader understanding of opportunities such as these, then we could see improvements in terms of everybody's buy-in to this effort. Okay, so the second area that came up a lot in our conversations was trust. Health plan members might not be comfortable sharing information about themselves. If they're not willing to do that, then any improvements we make to data collection systems are just going to be moot. And so we know the reasons for this mistrust: historic and present day structural racism, not understanding why the data are being collected or how they're being used, and then concerns about patient privacy and data security, and especially potential for harm, especially among historically marginalized people. So as one stakeholder said, a great way of framing this is it's not about a lack of trust on the part of an individual, it's about institutional trustworthiness. And so the stakeholders had some great suggestions for improving trustworthiness. So for instance, bringing individuals and communities into the development of categories used for data collection. So if people can see their own identities being reflected in the questions that are being asked, and also into the development of guardrails to protect privacy and trust. Also incorporating trusted community partners. So community-based organizations on the ground might be the more trusted individuals for someone to share their information with than other stakeholders. Transparency about how data will be used. People don't necessarily want to share their data if they don't know why they're sharing it and how it'll be used. And then identifying disparities, sharing those disparities with the community so they understand why they provided their data, but then engaging them at that point in developing solutions. Third, we found that many Americans, because they have employer-sponsored insurance, are providing their race and ethnicity to their employer. And so those the employer information could be used to share back with the health plan or other stakeholders. But many employers that we spoke with have concerns about legality and permissibility of this. I will be very brief here because we're happy to have Jim Klein, who can speak more about this. But I just want to flag one solution that came up in our conversation was the idea of federal agencies clarifying this legality. And I think the employers would also need to make some internal changes. They brought up concerns about not feeling that they're comfortable sharing their employees' data without asking them first if that's okay. Fourth, stakeholders maintain that outdated, inconsistent data collection practices can limit progress in data collection and storage and use. It's not new, but consistent with the prior literature, the solution here is updated data standards. Participants said that data needs to be self-reported, allow for multiple categories, be disaggregated for smaller subgroups, and be consistent so that they can be rolled up to the same level, but in different areas, perhaps different levels of detail to reflect the communities in those areas. But always, always, this came up again and again, be voluntary for people to decide. In addition, they said that there are some other things to keep in mind. Many highlighted that community input is needed for developing more inclusive standards for identification that reflect community identities, and that these transformations have to be accompanied by updated and more interoperable data systems for storing the data and sharing across different groups. And they said there's a lot more cross-sector work that we need for how do we know who should collect the information. Should it be the provider? Should it be the employer? The health plan themselves, government? If they're all collecting data, how are we going to share it? And then even if we are able to develop a system for sharing, we don't want to be asking people for the same information again and again. So how can we reduce that? How can we flag who collected the data, when they collected it, and if there is a discrepancy, which one of those identities is the most true for that person right now? So there are a lot of unanswered questions where we need work. And finally, we heard about a need for what one summit participant called a cultural shift. So elevating data collection and sharing among organizations' many different competing concerns. As one summit participant shared, this shouldn't be a siloed effort in a small part of an organization. It should be incorporated into the full strategic effort of organizations. We also heard that change is going to require collaborative effort, both within and outside of the healthcare system. And this change needs to start immediately because there's an urgency of the problem, but also it's going to take some time to get this all in place. So we need fast action. Sufficient resources came up a lot, not just in terms of funding, although that did come up a lot, but workforce capacity to collect this information in a culturally competent way. And then very importantly, guardrails to ensure data security and patient privacy and prevent harm, especially among historically marginalized people. And finally, working towards data collection, not just for data collection's sake, but for interventions to close these equity gaps. So thank you so much, and I will now pass it over to Jem Klein.
Thanks so much, Jenny. I also want to echo Jim and Jenny's thanks to Assistant Secretary Khawar and our partners on this project, but add to it a special thanks to the Urban Institute, which after all is the real leader in this whole project, and it's been a real privilege for American Benefits Council to be a partner with you on that. So why do employers care about this issue? Naturally, they want their employees and their family members and the communities in which they live to be healthy. And they want everybody to be treated equitably and fairly. But it's also important for another reason. It's important really to help achieve their overarching goal of delivering healthcare value. And as you all know, value really is the intersection of quality and cost. And if there are certain people who are not able to access care or they're not getting the right care, then clearly they're not the recipients of the highest possible quality of care. And if the quality is not as good as it needs to be, then the results will also be seen in increasing costs. So employers, as the sponsors of healthcare coverage, the largest sponsors of healthcare coverage in the entire country, clearly are one of the important stakeholders in all of this. As Jenny noted, a theme that winds its way through the report that you'll see when you read through it is this issue of trust and trustworthiness. We've been doing some public opinion polling going back to 2018, and by far, employers are the most trusted source of affordable, high-quality health care coverage. But let's be honest, this issue is somewhat different. And as Jenny noted, individuals have reasons for being doubtful about how this information is going to be used, but employers also have concerns about trust, including, of course, that they don't know whether they can trust that they're not going to be, creating public relations problems and also running afoul of the law or just simply inviting litigation. So we did some very non-scientific general survey, not as extensive and comprehensive as what you'll hear from Deloitte, but we wanted to just sort of test market, you might say, the kinds of things that we were hearing from employers in the interviews that were conducted as part of this project. And without going through it in great detail, because you can read it all there, most of the people who responded, in fact, do collect race and ethnicity data in their capacity as employers, but large employers in particular wear a second hat as sponsors of healthcare plans. And among the organizations that don't collect that data, they come among the most common reasons that they cited were the expected employee hesitancy and reluctance about it, and concerns about potential litigation. A number of those employers do collect that race and ethnicity data, but they don't share it with anyone. And of those that don't share it, they would need to have a lot greater understanding of how that information would be used by the health plan before they would do so. To sum it up, in the last bullet here, among both the organizations that don't collect the data at all, but collect it and do not share it, the most commonly cited reason for that action was their perceived or presumed legal barriers. So we commissioned a study to be done by two very eminent law firms with expertise in both employment law and healthcare law, Littler Mendelson and Groom Law Group. And what we found is, what they revealed is that there is no explicit federal law prohibiting the collection and use of this data for this purpose of promoting health equity. There's no prohibition on the sharing of this information either with the healthcare group health plans or insurers and third-party administrators. At the state level, for large employers like the members of American Benefits Council that are self-funded, have self-funded plans, there really are no legal barriers that generally would apply. But in the fully insured world, there are some barriers that the legal research discovered in respect to both state insurance laws and state privacy laws, but not as extensive as would be generally presumed. So to sum it up here, that's the reality, and obviously the legal analysis, which is included in full in the appendix to this report, goes into it in much greater detail. But the perception is different. And these are among the perceived problems. So what I think it all adds up to is that we need confidence-building measures. Jenny referenced what those confidence-building measures are for individuals themselves to feel comfortable sharing this information. From the employer perspective, I would just focus in on the one that she mentioned, and that is the desire for policy guidance from the federal government. Not a prescriptive mandate as to what they must do about it, but some sense of confidence that if they follow certain permissive steps, and if they're collecting the information for this not only permitted, but desired result of promoting health equity, that they will not be exposing themselves to litigation or run afoul of violating any laws. So I'm looking very much forward to hearing from our panel, but first I want to turn it over to our third partner in this effort, and that is David Rabinowitz at Deloitte Health Equity Institute.
Well, thank you, Jim, and thank you to Urban. Thank you to the full team at Elevance Health. It's been truly an honor and a privilege from the Deloitte standpoint to be a partner and a part of this very, very important work. I think as you heard from Jenny and from Jim, through this work, we were able to consult a pretty meaningful number of very diverse experts in the field, but we also felt it was really important to get directly into the community voices and the individual perspectives that underline some of the barriers and challenges that we've been talking about and are very detailed in the report. And so what we did is we brought in Deloitte's team of polycultural research experts who have been not only challenging our own cognitive biases on how we think about research from an inclusion standpoint, but also really moving the needle on how we're able to rapidly get insights that are actionable from a pretty wide range of groups, many of whom have been marginalized for many years. And so what we did, the slides go forward, is we commissioned a survey of about 3,000 American adults, and we asked the questions of, are you really willing or unwilling to share this kind of data with a variety of institutions, with your health plan, with your employer, the government, providers, and so on, because we wanted to really unpack what those direct barriers were. And we were honestly a little surprised by the findings. about 70% of respondents were in fact comfortable sharing this information for the uses that we've been talking about. And only about 6 to 8% of individuals were actively uncomfortable. The rest kind of chose not to respond. There were lots of natural and meaningful differences from a race ethnicity standpoint. Whites were slightly more comfortable sharing than other groups. But again, we were pretty kind of pleased to understand the findings and the implications that perhaps willingness isn't quite the barrier that we thought it was. And then when we kind of looked much more deeply into the groupings, especially from an ethnicity standpoint, we found meaningful differences between individuals from Central America versus South America, Southeast Asian, East Asian, and as well as kind of just the diversity and the richness of other ethnicities. But we did illuminate and surface a number of concerns that I'm sure are not surprising to any of us, privacy and data usage being paramount. A number of individuals were concerned about that they would be judged unfairly based on the sharing of this information. Many were fearful of discrimination. A significant number, 66%, fearful of government misuse of the data, as well as, interestingly, about 61% on average concerned that this would have implications for their own healthcare cost or coverage determinations. And at a time when there's so much rampant distrust in information, I love Jim's point that many trust employers, but I think we could acknowledge we live in a time where mistrust is certainly at an all-time high. This has, I think, some really important implications for how we think about what to do to solve the problem. It does reinforce that people are probably more willing to share this data with health plans, with employers, with others than rates of current collection previously might have suggested. There's obviously a huge difference between 70% of adults saying we're willing to share this and commercial insurers maybe having 10% of the data in the system. And though while there was a willingness high across all of the groups examined, there were some meaningful differences, again, from a discrete kind of race and ethnicity perspective, especially around kind of concerns about how the data will be used. And some of this became even more paramount when you start to unpack that the kind of the myth of heterogeneity, of homogeneity within some of the groups. So there's obviously a lot more richness from an ethnicity standpoint than the categories kind of lend us often to buy into. And then finally, this surfaced and supported a number of the recommendations that the report outlines. The easy one is the one on the bottom of the page, explain clearly how the data will and will not be used. It's part of a broader health literacy campaign. But the top bullet is the harder one, really recognizing that this requires localized and very community-driven solutions, and it requires wrestling with and frankly dismantling some of the systems of oppression that are behind the reasons why these structural and social barriers exist. And so I think to sum up, this really reinforced this notion that the system has to earn trust in a different way. And by putting inclusion and inclusivity at the core, I think we have an important set of voices in how to do that moving forward. So happy to share just a little bit about the findings. So with that, Jenny, I think I'll hand it over to Brian, who's going to take us through a wonderful panel. Thank you.
Well, good afternoon. Thank you all for joining us for this very important discussion. I want to start by thanking my colleagues at Urban, ABC, and Deloitte for a really terrific report, very comprehensive, very thorough, explaining the challenges with data collection. We all know that data collection is the linchpin of equity efforts. You all know that old saying, if you can't measure it, you can't change it. So clearly, the imperative for data collection has been there. For me personally, observing this issue for at least a couple of decades, been very frustrated and didn't understand why we were so challenged to improve our comprehensive data collection efforts, understanding that if patients fully understood the importance of it, if all of the stakeholders that work in the healthcare sector committed to advancing equity understood the importance of it, that we could just simply do it. but this report shows the complexity of the issue, the many facets, the many challenges. We cannot just mandate that this be done without thoroughly examining the attitudes, belief systems, behaviors that must contribute to this collective effort. So I want to thank my colleagues for this really important report. To add to this conversation, we have an amazing panel of experts who bring different vantage points to this issue because there are different stakeholders in this conversation. So I'm going to introduce our panelists. I'm not going to read their full bio. I believe you can access their bios in your packets and through the QR code that you see on the table there. And then just one little plea before we start into the conversation. There will be many questions I'm sure all of you will generate. As was indicated, for those folks that are participating virtually, you can type your questions into the Q&A box. For those of you that are here in person, you can just simply scan the QR code and we'll be happy to take your typed in questions. So to our wonderful panel, to my left is Nicole Evans, Director of Population and Public Health at NASHB. To her left is Shiloh Jones, Senior Manager of Health Equity at Families USA. To her left is Shantanu Agrawal, Chief Health Officer for Elevance Health, formerly Anthem. And then finally, last but not least, is Carol Mendoza, Vice President of Benefits at Voya. So thank you and welcome, and so pleased to have you join us. We heard quite a bit about the issues that our participants in the report generated, and there are a number of issues and opportunities. Let's start with some of those opportunities. One of the themes of the report is that there's a need for improved race and ethnicity data, not only to identify disparities, right, because as was said, we know that they exist, but to develop and assess interventions to close equity gaps. And as Lisa said earlier, the report outlines some of these, but we're curious to hear about each of your perspectives on the opportunities that improved data collection would afford to us. So I'll start with you, Shantanu. What is the value proposition of improved data collection? What are examples of initiatives that a health plan like Elevance Health could undertake if you had complete race and ethnicity data on your members?
Yeah, thank you. It's such an important question. And first, let me just start by saying I really appreciate the way this report was conducted, produced, sort of the research that went into it, the multi-stakeholder approach. I think it was a great, genuine process, and the result really speaks for itself. And so really appreciate the partnership of all the organizations involved. You know, getting this data is critical. I think, frankly, it needs to inform every aspect of our work and how we interact with our various customers and stakeholders. So we talk, for example, about addressing disparities. You know, we do know, of course, that there are disparities in quality, and prior to my role here, I've been very involved with the quality movement. But really understanding who is at risk requires getting good race and ethnicity data, and frankly at the right level, which I know we'll discuss later today. But this kind of data can also influence our customer service, how our members experience their care, how they access their care, the outcomes of that care. I mean, it really should infuse every process, every aspect of our work. I mean, it is truly that powerful and that valuable. Without it, we are often left in a position where we are guessing at what brings together a particular grouping of people or populations and why their outcomes are a little bit different. This can help to be explanatory really on the front end. And frankly, also without it, we're left to other approaches which are not the gold standard, right? We are talking here today about member self-reported race and ethnicity. Frankly, there are other approaches like imputed race and ethnicity. That is rife with challenges. It produces errors. And I don't relish the thought of creating programs that use imputation, that use population level data, because it's inherently less exact and I think therefore will produce, is at risk for not producing the best possible outcomes. And the last point I'll make, I know today's conversation is really about race and ethnicity data. I think it's worth pointing out that we need to get this right because there are other kinds of data that we also need to then move to that are just as important. Sexual orientation, gender identification. You know, we are as much focused on collecting those data elements as we are race and ethnicity because they're so critical.
Thank you for that. Carol, could you just describe some ways that employers are using this data?
Sure, thank you. I think employers had started doing this already in the retirement space. So looking at retirement equity, wealth equity, and to find the disparities and look for opportunities to improve outcomes. But with health, I agree that the data, we already know what the issues are, but we as employers can take that data, compare it to the gaps that we know exist in the healthcare system, and then make some inferences about why those gaps may exist. Because if we know that somebody is not adherent to a medication, okay, that's interesting information, but is it because there is a lack of access to health care, or because there's provider concordance, disconcordance with, I'm a transgender black woman, I don't want to go see an old white guy who's in network to talk about my issues. So having this data allows us to develop interventions that can, and communications that can help support our employees.
Thank you for that. Nicole, same question. What do you think are some of the most promising ways that improved data could not just identify disparities, but be used by health plans and other stakeholders to reduce inequities?
I will take off my mask. I wear it so much now I forgot I had it on. That's a great question. That's a great question. I think we're sort of in this weird moment where collecting data is supposed to drive us to an intervention. And what that intervention is, it solves a problem. I would offer and sort of challenge us to think beyond the obvious. Yeah, that's what we do data for. We see data in all the parts of our lives, banking, where we live, the kind of cars that we buy, and then it drives an outcome. What if we were to think about data as something that could inform change? Not just driving an outcome or solving a problem, but it just drives change. So I think about patient profiles and what a doctor gets when he's looking at its attribution. So these are all of my patients. Yes, the race and ethnicity data tells me how they identify. But what if we expanded that and we included income ranges and education levels? Then I have a better understanding before the patient gets to my office on how I need to prepare for the visit. What can I do in advance of them coming to my table, coming to the exam room? I rely on Medicaid. I'm not a Medicaid scholar, but I do consider myself a little bit of a specialist. I would offer that when someone steps into a doctor's office and they're a Medicaid beneficiary, they're already feeling uncomfortable. They already feel labeled because the card that they have to show doesn't look like cards for other insurance providers. Then they have a set of questions that they have to answer. That makes them even more uncomfortable about how they're going to be able to be treated, what kind of service and care they're going to get. I think the face of a Medicaid beneficiary has changed, and there are assumptions that sometimes our clinical staff give because that's what they were used to before. So what if we use that data to inform medical training that says it doesn't look like you thought it was going to look, it doesn't look like what your preceptors told you was going to look like. So your Medicaid beneficiaries now are white middle-aged moms who are taking care of their enabled differently children at home. It would kind of throw some clinicians for a loop because they're expecting a person of color at a certain income level, at a certain education level. So I would offer that, expanding that data to think differently about the experience and the encounter of healthcare, where healthcare takes place, how our clinicians provide themselves to be available for it, really seeds a thread of cultural humility. So the more you know, the more you can do. So that's what I would offer, is that we really need to look at it differently.
That's such a great point, using data to challenge stereotypes and assumptions. Shiloh, what does this look like from your vantage point as an advocate, someone working to bring research to the fore to address these issues?
Yeah, one thing I would add is just that it's really important, I think, to have this data in order to give a means for which health plans can hold themselves accountable to driving towards health equity, right? So similar to what Nicole just said, it's really essential that we have the whole picture, and we have the whole picture over time, we can track progress. And kind of going back to the importance of this in the quality measurement conversation, performance measurement, how are we tracking towards closing the gaps? We don't know that until we have the data. So that's one thing. And I think with respect to advocacy, having the data helps create a case for which advocates can bring to decision makers, policy makers. I think a lot of times when we talk about how do we engage folks that may not see the value in health equity and in the stories, having the data is just another way to shore up that backbone for arguments, policy asks, et cetera. When we think about what needs to be changed at a systemic level from a policy level, this is just really just one piece of the puzzle and one piece of the story that can be told that really can resonate with folks that would normally kind of shut their ears off when they hear about equity, when they hear about disparities and some of the stuff that we're much more comfortable talking about in rooms like these.
Absolutely. Another theme that the report really hit home on was the issue of trust and trustworthiness. Participants in the research noted the varied and valid reasons people may not be willing to share their data, including historic and present day unequal treatment and harms, or people not seeing their identities represented among the racial and ethnic categories that our federal government has designated, such as people of Middle Eastern and North African descent. And not being provided with an understanding of why their data are being collected or how these data are being used. As David mentioned, one of the top concerns among consumers appear to be concerned with informed consent about who their data would be shared with or sold to. Participants also recognize that gaining trustworthiness is a process that will take time. So even though we are all pants on fire urgent, this process will take time and require community engagement, accountability, and long-term commitment. So Shiloh, let me come back to you. What do you think will help build and maintain trust and trustworthiness so that health plan members feel comfortable sharing their data?
I mean, I think the first thing I'll say is pretty obvious, and you've already alluded to it, transparency, being really clear about where the data will and will not go. I think a real big concern is just the risk for punitive actions being taken for disclosing data or self-reporting data, ensuring and putting in clear terms, not just the really long terms and agreements sometimes you see, that where this will and will not go. And building in within this infrastructure, or data clearinghouse, whatever solution you choose, ways to opt in to sharing versus opting out. So making sure that yes, data is self-reported, but a person needs to know that each step of the way they're knowing exactly what the next throughway and pathway is. I think those are starts in being able to build trust. The other thing I'd add is just making sure that community members, whether they're community-based organizations, community health workers, those collecting the data, are not only, they're involved in decision-making and agenda setting when it comes to these issues. I think a lot of times when we think about participatory research, when we think about ways engaging the community, it's kind of you descend upon a community, you're saying that we're going to do an intervention, we're going to do all this research, we're going to collect this data, and then you go away. Finding ways, to your point, it's going to take a longer amount of time and a longer amount of genuine investment and authentic investment and feedback loops and changing and course adjusting and listening to that feedback.
Yeah, thank you for that. Nicole, from your vantage point at NASHB, can you share some examples of states that are doing this right with community engagement and community investments to address distrust?
Absolutely. I think it's a wonderful thing to talk about community engagement, but that's misleading. Communities want an investment. They don't want you just to show up for today and tomorrow. They want you there long term. So how are health plans really evidencing that, and where it's at the state level are some interesting partnerships. I turn my eye to Tennessee, and the state's public health department has just solved the problem for all of us. Invest in the historically black colleges and universities in your state. Many of them are teaching institutions for medicine. They have schools of nursing. They're putting out the practitioners who are going to be part of your provider network at a health plan. So start earlier up in the pipeline, making sure that their exposure levels really reflect the communities that they're going to be able to serve. The other piece of that is I think we need to normalize collecting data. If we're squeamish about it, then the communities are going to be squeamish about it. If we don't have a certain level of confidence to say this is just what we do. And it always strikes me as interesting because we already collect data. We already collect race and ethnicity data, but when we get to this one little spot, there's this hullabaloo and kerfuffle about what we're going to do with it. But we collect it when a baby's born. It's collected when we pass away, which is a rabbit hole conversation in and of itself, that it starts and ends that way. But along the way, why is there such a big deal about collecting data? Those communities of color that haven't participated in the opportunity, and I say opportunity intentionally, to have basic medical care aren't going to welcome folks with open arms and say, you've got a problem and we're here to help you solve it. So I think we need to look at the ways that a state is doing it, and it's not always through the Medicaid program. State public health departments and local health departments are really making changes in how they view health equity and integrating it as a foundational element of the work that they do, not another thing that they do. So health equity, I mean, our dream is that it becomes something that we don't have to talk about because it's already in place. But until we get there, I think that that's what we need to look at, is how states are really managing those community partnerships. There's no expectation that a community partner comes to the table with resources and time and evidence to be at the table. There's just a seat for them. Maybe it's building capacity and infrastructure and taking them down that road. But that trust building piece, that getting over the distrust and mistrust, it has to be an ongoing partnership with communities. And not just because there's something invested and somebody gave a lot of money in a grant and said, let's look at maternal health here. There has to be well, we're looking at maternal health, and we notice that the NICU only has 6 baby beds. So part of our outcomes are going to be increasing the number of baby beds in this hospital's NICU because it's in a community of color. And we're seeing a higher rate of babies who end up in the NICU here. So carrying out the hypothesis, carrying out the question to how it benefits the community, not just gives evidence to be published. I think those are some of the better steps to take.
Great example. That's a really good point. Relatedly, many participants in this study emphasize that people from historically marginalized groups fear being discriminated against if they provide race and ethnicity information to health plans. There was agreement that individuals and patient advocacy groups, along with other stakeholders, should be engaged in developing guardrails. What are some of the specific ways action could ensure individuals' privacy is protected and that better data collection doesn't cause disproportionate harm to the very groups that are already being less well served by our healthcare system? Nicole, I'll start with you. What are some guardrails that you think are important?
Guardrails is a term that always makes me nervous because it gives the implication that something bad is going to happen, so we have to protect ourselves from it. But I think if we flip that and we think positively about how do we make sure that we're doing no harm? How do we make sure that the data that's being collected is going to be used against the community that it was collected from? So I think shifting the paradigm there is just evidence of how we develop the guardrails. We have to think differently about it. We look at the relaxed restrictions that we've seen over the course of the pandemic. Many of them worked. They provided new access points for care in rural communities, provided new access points of care for folks who are having a hard time in making a doctor's appointment on their lunch hour. Telehealth gave them health at home. I'm sure we all, I know I've used it and used it recently, the opportunity to have telehealth because I couldn't get to see my provider for another 6 weeks. So telehealth was right there, came in the next day, we had our conversation and it worked out. So I think there are some spaces where we need to shift not just the work we do or how we do the work, but how we think about what's being collected and how we think about the intersection and what that intersecting point is. So in terms of guardrails and protections or patient safeties, I think the focus should begin and end with the patient. What do they want? What are they thinking about? What are they concerned about in terms of misuse? Are they concerned because you might sell it? Well, then let's address that. Are they concerned because they don't understand why you asked for it? Well, then let's educate and share why we're doing that. So instead of coming up with these words and labels that communicate something awful could happen, because we see the guardrail on the highway, that's supposed to protect us from going off the road, right? So let's think about it differently, about how do we protect our patient safety? How do we think about ourselves as individuals, groups, and communities? And this is being collected in a way that's building us up and enhancing what we're doing. So we're covering all our bases. So I would say we need to shift in how we think about it and stop calling it a guardrail, but call it a patient safety.
Yep, great point. Let me ask you the same question, Shiloh. What are some patient protections that you think would be important as part of this effort?
I think going back to opting in versus opting out is going to be really important because it gets to the trust and making sure, also a point that made earlier, just that collecting data should be intuitive, should be easy. It shouldn't be something that is asked over and over, ask once, and finding a way to have that data travel with the patient or with the person so that they're not asked every single time, because one gets suspicious if you're asked over and over and over the same question. So I think, and also making sure, maybe it's a prompt or a notice that your information is being shared with XY entity, and making sure that that's, again, transparent and clear and easy to understand. Other guardrails, I think something to be considered, just language accessibility, making sure that when you're collecting data, it's in a way, in primary language spoken. I think we haven't really talked about race, ethnicity, and language, I think is another big aspect here. So finding ways to collect data that is comfortable for the person, in a way that they understand and they know where it's going and where it is, again, where it is not going.
Great, thank you. Shantanu, how can a health plan build in these important protections for patients?
Yeah, so I agree, of course, with everything that's been said. I mean, there's I think some really basic guardrails that we have to adopt and communicate around, right? So we're going to secure your data. We're going to use it only for purposes that are very clear to you and that you approve of. We're going to be using it to actually improve your health, the health of your community, right? And getting people involved, being transparent about it, all that is right. I think there's maybe a couple of other things I think about. One is, and Nicole, I think you made this point, having an action orientation. I mean, this is not, we don't want to collect this data. This is very, I'm a ER doc, like I think about this data the same as getting somebody's blood pressure. The whole point is to act on the outcome, to act on what you've collected, not merely to collect the data. I think that's got to be communicated so it doesn't sound to members, to patients, solely like a research effort. I think the other point to be made is, look, I don't know that there's any organization, healthcare organization around the country that's not working to address equity, that's not working to address disparities, but the reality is this data will really jumpstart those efforts and move us forward much more quickly. It will refine those efforts, right? So right now, we're engaged in trying to get equity into our quality programs, into our public transparency programs. They're being embedded into our value-based contracts with providers. But take that as an example. Right now, what's being embedded, or what we're thinking about is, well, we'll incentivize the provider to report the data to us. That's a great first step in the absence of this kind of effort. But imagine if I had that data, I could incentivize them to look at their data, to address disparities, to really act on equity. I'm reminded, too, of another example recently. CMS, under their equity agenda, recently evaluated CMMI models and actually found that some models were potentially at risk for not having addressed implicit bias. That is the kind of thing that we should be doing across all of our programs. In order to do that, I have to I have to be able to look at the potential sources of implicit bias and really find those discrepancies. So, yes, I don't know if it's a guardrail. To me, it does go directly at this issue of trust. Like, tell me what you're going to use it for and convince me that you're going to act quickly on the findings.
Very important point. Another theme that emerged from the report is the question of who should collect the data. There's a lot of finger pointing, right? And historically has been. One of the potential ways to improve data collection that came up in this research is for employers to provide race and ethnicity data on their employees who are covered by their group health plan to the plan, as you heard. Many are already collecting such information as part of Equal Employment Opportunity Commission requirements, but not many are sharing it with plans, as you saw from the data that were presented here. Often because they're worried about legal risks of doing so. But as Jim explained earlier, a detailed analysis of the legal landscape shows that no laws were found to stand as actual legal barriers to the collection, storage, use, or disclosure of these data for permitted purposes, including to reduce disparities. One of the resources this report brings to the conversation is spelling out this lack of legal limits. But this raises, of course, additional questions. So, Carol, from the employer human resources perspective, assuming employers understood this was legally allowed and they could modify their existing employee data consent contracts to do so, how willing would employers be to share these data with health plans?
I think employers would be willing to share the data if they saw the value for themselves in sharing the data. Part of it is wanting to be part of the greater good and helping to solve problems. But I think some employers have also been concerned about, once they get data back that shows that there are health inequities within their own population, well, am I going to be held accountable for that? Am I going to be in trouble because we have those inequities? So if a health plan is asking for the data, I think the health plan can also share how you can partner together, the health plan and the employer, to do something with that data that's actionable, that's meaningful, so that we're actually doing something.
Right, exactly. And in follow-up, building on our discussion of protections, what protections could be built into systems? So, Shantanu, how do we keep the appearance of regulatory or legal issues from standing in the way of action on this issue?
I have to tell you that I was really glad that this effort looked into this question in particular, because I don't know about the rest of you or others that have read the report. I was frankly a little surprised by the result. I think the perception that this is somehow prohibited or that there's massive barriers to collecting this data way overwhelms or sort of has outstripped the reality. Yes, I mean, the report, I think, uncovered that there are some maybe important state-level differences that we have to address. But this is really critical. I mean, I think part of the answer to the question is we've got to have conversations like this. I mean, right now that such a report has been produced, this is a dialogue to be had with all of our employer customers, and really to be able to discuss, look, here's the value that we see in getting this data from you about your employees. Let's think about what the plan around that looks like, and be able to use this report as sort of yet another data point that this is not prohibited in some serious way. I mean, I think it opens up a level of dialogue that I wasn't even certain how to approach without somebody having done the research to this level of detail. So I really value that. I think it's the discussion, it's the communication, it's again putting everything that we've been saying on paper and being able to identify for employers and their employees what we can do to benefit their health with this data.
Absolutely. I was struck by that as well. Yeah. Shiloh, if employers are willing to do so, what are your thoughts on employees' comfort with sharing? We saw some data on this, but let's unpack that a little bit further.
I think the data showed earlier wasn't surprising in that folks probably would be fine sharing the data. Again, it goes back to the trust conversation, though. It's just making sure, okay, I already had to give this data to my employer, so it's not an extra step per se. It's just more so, okay, this is where it's going to go, and that's what it's going to be used for, to help target any solutions that'd be offered to me. Sure, why not? I think it's more so, particularly because I think it showed earlier that employers tend to be a more trusted messenger of this information. Yeah, I don't think that there would be obstacles in terms of employees being willing. It just goes back to knowing what it's going to be used for.
Absolutely. At this point, I want to remind folks both here in the room live as well as folks watching virtually, please feel free to type in questions. If you're watching virtually, it's in the Q&A box as you typically would do. Here in the room, you can just simply scan the QR code. We've got a lot of great questions coming in, so I want to preserve as much time as possible for this discussion. But just a few more issues on this point about who should collect data. Employers obviously could not be the only ones to collect this data for several reasons. For instance, employers don't have information on spouses or children that are covered by employer health plans. And of course, more than a third of Americans have public coverage, such as Medicaid or Medicare. The report also discusses providers, community-based organizations, and health plans themselves as entities for collecting and sharing individuals' data. These likely vary in levels of trustworthiness as well as in terms of technological and resource capacity to do so. Shiloh, what do you think is the best entity, or who do you think is the best entity to collect data? Should we designate one collector, or should every sector within the healthcare space be doing so and then sharing across sectors, or do we all need a little chip implanted in our skin with our demographic data?
We'll see how well that goes over.
That's another panel there.
I think our system's very fragmented, and every single sector has a part of the population that they don't touch, per se. So even if we're thinking about health plans, there's uninsured. Even if we're thinking about safety net providers, there's those who don't enter until they reach, the emergency room. So therefore, I think, ideally there'd be some sort of national, federal clearinghouse where the various sectors would be able to report into, be able to share that data. I think, and also that would enable the data to be comparable across states. As I think another issue that was highlighted earlier was just when we think about how how we're determining the categories, making sure that that's standard across states, across communities, across systems, because otherwise it gets really difficult to really drive at specific targeted solutions, and then further more solutions that cut across different intersectional demographics as well. So I think ideally it'd be something that data would be shared and it would be collected through the various avenues, but in a standardized way. That's my take on it.
Yeah, thank you. Nicole, same question. Who's best positioned to collect and share these data?
Well, I'm known as a disruptor, so I'm going to disrupt that question too. The individual collects the data. They know their race and ethnicity. I think we need to focus on when it's reported or when it's shared and how it's shared. And again, that puts the honor back on the person who has that data as opposed to an individual third party or second party saying, give it to me. So it says, all right, you've got the data, you know it. Where are you going to share it and how are you going to report it out? I think that's a different way to look at this, and it gives that empowerment to the person, not necessarily the system that's looking for it. And we're all in it then. We're all in a partnership. They step to it in an equitable way. I also think you collect once and you use often. Don't keep collecting. I think communities of color are just oversampled. We're tired. We're really tired of the surveys. We're over the questions that come all the time. But the action on it piece, we're less concerned with as much as we are frustrated that I had to answer this when I got hired. I had to answer this when I went to the doctor. I had to answer this when I got a driver's license. So collect once and use often. But again, go back and empower the people who own the data, and that's that individual, that person, and give them the opportunity to share it at their discretion, at their choice, and emphasize that it is a choice. Yes, we'd like to have this data because it would offer us this information, but this is your choice. And if you choose not to, life will go on. There will be no punitive things for you. We will keep chipping away at the problems. You're not hindering us, but let's look at this differently as the person who owns the data, which is the individual, and how we can empower them to be comfortable to share and report it.
Absolutely. Carol, from the employer perspective, are you in favor of the plan collecting data from members, or should the data be collected by all these different entities and then combined at the plan level?
Yeah, I would love for the plan to collect the data. I think having one place where it's collected, and the data is consistent, so to the point about the different descriptions of individuals and how you described yourself, and the ability to check that I am this and this and this would be really helpful. So I think having it collected by the plan, having it be consistently collected would be helpful.
Absolutely. Some participants had mixed feelings about this, but with some saying that those closest to the patient should collect the data, and other providers saying that's a breach of trust. So Shantanu, what's your perspective on this issue as a provider and a leader of a plan?
Yeah, I think it's all of the above. I think there has to be an answer for today and hopefully a different answer for 5 years from now. The answer today is I think we have to recognize the massive gap that we're in. So, the plurality of Americans have employer-sponsored insurance, and the vast majority of those Americans don't have this kind of data reported to the plan. So we're talking tens of millions, maybe upwards of that, in terms of the data gap today. So I think, yes, the plan, the employer, the provider, I think it's, again, try to hew to these principles that we have of actionability and doing something with it. If you're going to do something with it, collect the data, and then let's figure out how to share it. A plan like ours, we collect for the purposes purely of quality measurement and reporting every year, quality improvement activities, about 500,000 medical records from providers. And what we found is that when providers are proactive in collecting this data, they put it into those records, almost a second nature, and then we have that data. So there are imperfect, but even today, approaches to interoperability that can allow this data to flow in a really appropriate way that is also secure and that's usable and that we can put into action in our quality programs. So I say, let's use all of that. Let's start collecting today, and hopefully when interoperability, as we all envision it, is a total reality tomorrow, the answer to that might look a little bit different.
And could I add a point to that? I think it's important with the providers to provide guidelines for how you collect that data, because if it's visual identification, I think Absolutely. That you are a little white boy. I think about my son. He's half Mexican, half Northern European mutt. The provider isn't going to necessarily know what his ethnic background is, so it needs to be self-reported and then shared.
Yes, absolutely.
Can I tag on to that one too? I can't let that one go by. I think we need to get out of this space where we're honoring race, because race is a social construct. It reinforces the division and the identity of someone based on the color of their skin. when we step into a space and we normalize data collection, then we have to own and say that we all come from different places and different spaces, and it could be anything. I also think that we need to stop relying on the census categories. The census categories drive one thing. They're not supposed to be multidimensional. They're just for that one thing, and they're good for that one thing. But that's a good place to start. So asking someone, hey, you know, in this group, do you identify as Black African American or do you identify as Caribbean? Is a space to start getting that data and educating providers on how to ask it and not rely on just what they see.
And that's not just categories and semantics. It matters from a health standpoint, right?
Yeah.
You know, when you quote unquote check a different box, it actually can tell the physician, the provider, something else about your history, something else about your risk that they might not otherwise know. And if you checked a different box, they wouldn't have the same understanding.
Agree.
And so here's a question related to that that's very important. Participants during the summit raised a number of questions, including what to do when multiple sources of data have different categorizations of a person's race or ethnicity. How do we determine which is most true? And particularly if we're collecting data from a variety of different sources, we might get a variety of different answers, and it also depends on the context, as you said, Nicole. So how do we resolve that? I open this for anyone.
I think, and I don't know the answer to this question, but which one is more closest to the patient? Which one was self-reported and had the most fulsome list of possibilities? That should probably be prioritized, and then you fill in with whatever other data you have.
Exactly. And of course, we all have multiple intersecting identities. But to your point, Carol, one of the worst things you can do is ascribe a category to someone. It has to be based on their self-identification. Right. All right, I'm going to quickly pivot to one other set of issues, and then again, we've got a number of really outstanding questions that are coming in. This set of questions is on federal and state action. Like other research before this report identifies a number of proposals that would require federal action. For instance, federal leadership would be needed to update outdated data collection standards, as we've talked about. The OMB5 racial categories and 2 ethnic groups don't reflect the lived reality for many who live here. These data standards don't have enough granularity currently to capture the diversity of the nation. And participants thought one way to reduce perceptions of legal barriers was for federal agencies to explicitly clarify the legality and permissibility of sharing for this purpose. There are already calls to improve race and ethnicity data collection during enrollment for Medicare Advantage and prescription drug plans. States would also have to be involved, especially in terms of Medicaid, where states are collecting race and ethnicity data in Medicaid applications, but the categories aren't standardized across states, as we've noted, inhibiting comparability. And a recent MacPac report found that the files submitted to the federal government found that only 19 states reported complete race and ethnicity data for 90% of their records. 3 states reported incomplete race and ethnicity data for at least 50% of their records. So we have got a broad problem requiring federal leadership. What's the likelihood of broader federal and state action to improve data collection? I open that up to anyone.
You saved the best question for last.
I don't know the likelihood, but it's necessary. You know, who you put in sort of in charge of that or to coordinate it, I'm not sure I have a perspective on. But there are clearly important differences by race and ethnicity that matter for health outcomes, and this also intersects with immigration status, which matters for health outcomes, right? So, you know, I think we've got to get to a much more specific level than the sort of categories and boxes we have today. I'm reminded, you know, a few months ago, my daughter was filling out an application for something, and she asked me a question that I could not answer, which is, am I Asian? I was like, I don't really know. I think we are. I was like, what are the options? And the only closest option was Asian. But let's be honest, like, I mean, and obviously speaking from a very personal standpoint, there's a huge difference between being South Asian and being Asian. And I'm not just saying from a self-identity standpoint, but from a health outcome standpoint, right? We are at risk, South Asians, for cardiovascular disease at a much higher rate than our Asian American brothers and sisters. And if you are a recent immigrant that is notably different than if you have been born and raised in the United States, even of South Asian ancestry. So we do have to get this right. I think that kind of rationale and reasoning applies to basically every ethnicity. There are clearly things I don't know, too, about other ethnicities' kind of risk factors. We have to take a health lens on this question and make sure we are segmenting things in a really appropriate way that matches outcomes.
Absolutely. Nicole, from where you sit at NASHB, where are the states on this issue? Are they increasingly focused on health equity, particularly as they pivot from the pandemic-related public health emergency to other issues? And we saw, obviously, the challenges around data collection during the pandemic, which really inhibited our ability to target resources and address the risks that some populations experience. So what's your sense about where the states are on this issue?
That's a great big question when some of the states have a different perspective and are a bit more conservative when it comes to health equity, and then others have really embraced racism as a public health crisis. So I level set there that there's a broad spectrum here. I would offer that the National Academy for State Health Policy has done an awesome job in preparing its annual conference. That's a silent plug. We are September 12th to the 13th out in Seattle in person. But I share that because the most registered sessions for our conference are the ones around equity. And this conference is it's designed, it's the premier one for state folks. So it's on their mind, but on their mind, I think, in a different way. COVID drove a lot of the light and funding for work that was done around disparities during this time. The problem now for states is how do we pivot when that funding changes? And how do we make sure that we haven't set up communities for failure by giving them all of this resource and relief, and then when the public health emergency shifts, we're out of luck, which would take us back to where we were pre-pandemic and dealing with some things that we thought we'd already solved. So yes, it is a hot topic.
Yeah. Quick question for all of you before we pivot to questions from our audience. There is a real question. What federal agency could be leading this? Some that came up during the research are EEOC, Equal Employment Opportunity Commission, Treasury, Health and Human Services, Labor, Office of Civil Rights. Who can effectively lead this effort from the federal side?
I think you named them all. I think it needs to be a collaborative effort. I don't think this should fall just in one bucket because then that one agency is on the hook. I think it needs to be a shared experience, and that would evidence to us as Americans that we need to share in the outcome. If it doesn't start with that kind of modeling at the beginning, I don't know where we'll go on down the road.
And I'd also add that all of those agencies kind of administratively work in different ways. So I think about, from a payment delivery system reform perspective, an intermediate step is to tie the collection of data for hospitals to quality metrics, to not just quality, I guess, in terms of like reimbursement, thinking about models, thinking about what CMI is doing, and trying to really drill at and incentivize, create financial incentives. I think that's a good intermediate step that can be done through HHS or other agencies within OMB, thinking about standards and pushing them to contract and develop and update those standards and therefore mandate. That's, I think, a role that administratively can be done at the federal level.
Yep. We've only got a few minutes left, and the next set of questions related to next steps. Jump-starting action, which is another theme in this report that I really appreciate. Rather than saying it's an intractable problem, and it certainly is a challenging problem, this report focuses on what is needed next, understanding that this is a long haul, right? We will not solve this in a day, a week, or a month, or a year. But what is needed for next steps? And one of the great questions that we've had from one of our participants, either virtually or here in the room, is what would you or your organization need, and from whom, in order to take the next steps in sharing, providing, or collecting data? I open this up for any of our panelists.
That's a good question.
What would you need to be able to immediately take steps to share, provide, or collect data?
So I think the report has provided a really solid foundation to start having some great conversations with our employer customers, right? It has dispelled some myths. It has kind of indicated what the opportunities are. And I mean, that is something we are going to be doing. That's one of the hopes coming out of this report, that it would become kind of a catalyst for having the right collaboration with our employer customers so that we can start remedying that sort of area of deficit in our data. You know, everything else, this is about, we have balls in motion already in terms of equity, like I said earlier, as I'm sure all of the other organizations do. We are going to continue pushing forward on that. We have other processes for trying to collect this data. We are collaborating with providers to do that. So all of that continues. I think perhaps the real inflection point here is what we can do with our employer customers. So I look forward certainly to that.
Absolutely. Another question that has come in from one of our viewers or participants in the room. What does community engagement look like? We've talked a lot about community engagement, and we've said that it is critical. But what is it? What does it look like? And what are some examples of how different stakeholders who are here, plans, providers, employers, what are some examples of how we can engage with our communities?
Community engagement is an interesting word, but it needs to be used accordingly and appropriately. And I think that's what this report gives us. It gives us the opportunity to talk about health equity in a way that we're all speaking the same language, that we have this center space that we can start at and then we can go above there. But community engagement needs to elevate the community investment. I think that's probably the more appropriate term when we're talking about hospitals and how they're using their funding. We're talking about community benefit. Again, these actionable words that give an actionable outcome to what they're doing. So community investment looks like putting the dollars behind what you said you're able to do. It's not just, hey, we're going to work on infant mortality. We've done these things. We've done the research. We see that it's centralized in this one area. So we're going to descend on this centralized area. It booms the economy for what, 2 years while the work is being done. And then after that, we've got a lot of vacant apartments. We've got an economy that starts to slump. That investment didn't happen. It was temporary. So maybe the investment is you work and you do the work for 2 years, but you also invest in the community college's workforce. You also invest in continuing education programs that can be less expensive than a 4-year university. You're building out the workforce. We haven't talked about, that's the backdrop to this, asking for data from someone who doesn't look like me. I'm immediately concerned. I don't know if this person is going to be responsible enough to use this data the way they say they are, or if they're going to give it to whom they said they're going to give it to. But when it comes from somebody that looks like me, and I can say, you know what, we're working on this project, and I really want to make sure that it benefits our community the way we intend, and it's around women of color. But I need to ask you, how do you identify? I would imagine she'd probably have an easier time saying that to me than someone who doesn't look like me. So I think that when we're talking about community investment, we have to look at the gaps in workforce diversity. Sending a bunch of researchers and headwigs and other folks to a community where they can't relate, they step out of a car in 3-piece suits, and the community that they're serving is struggling to figure out how to put clothes on their children. They're having meals catered during the day so that they can eat, but you're in a community where it's food insecure. These are some of the awarenesses that become community engagement and take it to community investment.
One thing I'd add is just thinking about partnership and creating an ongoing feedback loop. So in addition to all of those activities, making sure that there are new mechanisms for the folks in the community to speak right to the folks making the decisions, to tell them this isn't working, this is what I'm seeing, this is what us in the community think that we should go instead of where you may have originally charted out. So it's a big part of community engagement is partnership, authentic partnership with the folks that have lived experience that's just as relevant, it's just as important, it's just as worthy as anything else in terms of figuring out how to get at collecting this data in a way that is going to resonate and makes people feel comfortable and empowered to do so.
I'd add that you need to continue that partnership through the evaluation stage of any work that you're doing. It's great to have them at the beginning, but keep them at the table to decide whether it worked. Right. Did it work? Did it not work? Was it effective? Did it reach what they wanted it to reach? To reevaluate, maybe course correct, and do something different.
Yep. Partnership can't stop after you got the data.
Right.
Nope. Great. All right. Here's a question specifically for Dr. Agrawal, because you referenced the issue of imputed data. To the extent that we do not have and will not have anywhere near complete individual level data in the near term, what do you propose for players in the healthcare space that only have imputed or population level data? How can we think about the process of utilizing the data we have available now and the process of transitioning over time to rely more on patient-provided data?
Yeah, it's a great, really important question. So the reality is we have to use essentially proxy data in some form or another, whether it's on the race ethnicity issue or social vulnerability or whatever else, right? There's multiple domains that it would be very helpful to have data reported on by the member or patient, and yet we just don't have it. So, the alternative is to do nothing, which I don't think is a reasonable alternative. So you have to start somewhere. So we, like everybody else, I'm sure, use proxy indicators. I think it's really important to understand that those are proxy indicators. They are approximations. They're based on population level surveys, or they're based on imputation models. And so our sort of in-house quote unquote rule is they can be used for identifying issues. They can be used for kind of discernment, identification of disparities. But we can't act solely on those data, because that's when you get headlong into trouble. Because there are assumptions built into the models that you don't want to act on, right? So once you've used that data, and I think it's reasonable to use it for issue identification, you then do have to get in front of the right member, the right population, and that can prompt who, so that you're using your resources in the right way, but you've got to then get it from the member in order to actually implement an intervention. Don't do it on the population level data.
Yes. Carol, given that the public has been subject to many leaks, abuses of their privacy, and selling of information without knowledge where it really goes, and has good reason to be wary of data collection from virtually any corporation. I'm just reading the question verbatim. What sort of efforts would need to be taken to inform the public about how their data will be used?
Yeah. I think it goes back to the guardrail question, and how is the data being collected and how are we using it, and being very explicit about how that data that is shared with the health plan will be perhaps cordoned off, so it won't be used for underwriting purposes, for commercial insurance at some point in the future. It is fully for the benefit of plan members.
Yep. Great, thank you. Here's another great question, and this would be for anyone who wants to take on the role of director of OMB. What is the panel's suggestion for the overall race and ethnicity options that granular options can be mapped back to, right? If you were the OMB director and could change our racial and ethnic categories, how would we do this in a way that we can have more granular options that can be rolled up?
I'd start by getting rid of the word race and focus more on heritage. I think about more things that identify with origin. What is your origin? Where is your country of origin? Where is your place of origin, as opposed to that one box that says race? Because when we hear that, we think black, white, and it doesn't go much further. So I'd get rid of the word race. I'd also encourage an ongoing evaluation of the composition of the American citizenship. It changes every year. It changes within a year. And to wait until we get to the census just to do it seems like we're creating our own gap and shooting ourselves in the foot. So I'd invoke, because I'm the director of the OMB, a different cadence for evaluating the composition of America. I think about all of the folks who came here from Afghanistan, about all of the folks who are now here from the Ukraine. We want to honor their space in this country, but we do so in a way that's respectful. So let's reevaluate now that we have all of these new, wonderful, culturally different folks here. Are we really paying attention to that when we talk about the categories?
Yeah, how do Americans identify? What to average Americans would be the most important categories? We know where the disparities are, but how do people identify? And importantly, again, the question of intersecting identities has come up. One person writes, when collecting race and ethnicity data, we want to allow individuals to be able to select as many identities as they feel apply. However, this leads to challenges around analysis. What's the best way to aggregate statistics when you allow for this selection of multiple identities? Again, I pose this to anyone on the panel, recognizing that we just have a couple minutes left.
I'm a fan of disaggregated data, so I'm not going to answer. I don't like aggregated data.
That is challenging. I mean, I think you need a statistician up here to really, yes, I mean, it's, look, most of the time we're given only one option, right? You have to pick one. And that is for ease of analysis. It is not to reflect reality. I think the question is genuine, and it's a really good one because the person is trying to, really address, what does it mean to genuinely understand somebody's background? And I love the idea of eliminating race. That's fascinating. I think, gosh, it just does not. It does not seem as open to analysis at that point. I think we'd have to really think through that.
I think you have to think about where you're going to use it. I mean, if we're looking at somebody who's identified in a number of ways, then let's not look at that as like the hiccup, but let's look at that as the smooth on-ramp to where we're going to use it. If you're using it because you want to analyze and get to a point where an intervention addresses a critical space, then you already know what you're looking for. If that critical space has predominantly been women of color between XYZ age, then those are the characteristics that you should pay attention to. When you get more than what you need, only use what you need. Don't open the door to try and figure it out. Okay, so I've got 7 criteria now and I only needed 5. What do I do with the other 2? Don't use the other 2. If you were focusing on the first 5 as your hypothesis, then stick with that.
This has been an amazing conversation. Please join me in thanking Nicole Evans, Shiloh Jones, Shantanu Agrawal, and Carol Mendoza. Really wonderful discussion. Thank you so much. Wrapping up today's program, this is obviously an issue of both urgency, but also it's a long game. We all have to be engaged in this because we each have a role to play. We're all stakeholders in this effort. So I hope you'll stay tuned to the work that we are collectively doing at Urban, ABC, and Deloitte. Please stay tuned to the Urban website. There will certainly be more work to be done to advance this issue. Thank you so much for attending and coming today. Great comments.
Thank you. Thank you. Thank you.
Absolutely. You might be invited back. Oh, that was super cool.